Okay, good afternoon, everyone. It's 12 noon. Welcome to Medical Grand Rounds. Our rounds today are courtesy of the Division of Gastroenterology. Just a reminder to please enter your questions at the end of the chat into the chat, and please answer a brief survey that will be sent to you at the end of the presentation. I would like to introduce our speaker. I see Alain there, unless you wanted to. I was going to introduce our speaker today.
Okay, can you hear me?
Yes, we can. Would you like to introduce Yanni?
Yeah, can you hear me or?
Yes, we can hear you, Alain.
Yeah, it's a great pleasure. Let me introduce Yanni here. So it's well, welcome everybody to Grand Rounds. It's my great pleasure to introduce Yanni Chen, one of our rising stars in gastroenterology. So Yanni currently is the Glenn Site Director of Advanced Therapeutic Endoscopy, and he did his core GI training at McGill, and he did a 2-year fellowship in Advanced Therapeutic Endoscopy at Johns Hopkins University. And when he returned, he really set up an excellent clinical and research program in the assessment of novel endoscopic technologies. And as I said, he is a rising star. He's FRQS funded and CIHR funded. So we're very proud of Yanni. And Yanni's going to talk to us today about endoscopic management of pancreatic cancer. So Yanni, take it away.
Thank you, Dr. Bouton, for the introduction. Really appreciate it. Thank you, everyone, for taking the time to come to Rounds today. Let me just share my screen here. Okay. I think everyone can see this. So once again, thank you. Today, we're going to talk about endoscopic treatment of pancreatic cancer in 2022. My talk will not be, I don't think, all the way to 45 minutes. It will be around 40 minutes or 35 minutes. So it won't be too long of a talk. And hold on a second, I can't move my slide. There you go. Here are my disclosures. And like Dr. Bouton said, most of what I'm going to discuss today, many of the projects that we will discuss were funded by the Canadian Institute of Health Research. And I'm also a Junior 1 clinician scientist on the research track for clinical work and 50% research. Here are the objectives for today. Our goal is to understand the current gold standard for tissue diagnosis in pancreatic cancer. We will also look at the different modalities for biliary drainage. As you know, this is a very common complication of pancreatic cancer where patients present with jaundice and bile duct obstruction. Another very common complication of pancreatic cancer is gastric outlet obstruction. So we will also discuss the different modalities to treat gastric outlet obstruction in 2022. Endoscopic ultrasound, I'm not sure who is familiar with this approach, this modality. Just to give a little bit of a sidebar, José Parent, who many of you know very well, was the first person in Quebec to do endoscopic ultrasound and the second person in Canada to do endoscopic ultrasound. So we're very grateful of her pioneering work at McGill, and we're also following her footsteps. The idea of endoscopic ultrasound is that it is very similar to a regular endoscope, but the main difference is that it has a echogenic tip, basically an ultrasound attached to the tip of the scope, which allows you to see through the stomach and duodenum and into abdominal organs such as the pancreas and liver. The reason we use echoendoscopy for the pancreas is because we need to remind ourselves that the pancreas is a retroperitoneal organ. If you want to do any sort of biopsies from a percutaneous approach, it is very far away, and you need to traverse many structures before getting there, putting it at risk for seeding and putting it at risk for damage to other organs. So as you can see on this diagram, we're able to get very close to the pancreas with the ultrasound probe, and we can puncture very easily into any parts of the pancreas from the uncinate all the way to the tail, either from the duodenum or stomach, and get the tissue in that fashion. Now, the only thing I would say, the weakness of echoendoscopy so far has been the fact that we use fairly thin needles, 22 gauge, and these needles are fine needle aspiration, and we are unable to get good histology. And we know that from the previous literature that tissue acquired through fine needle aspiration using endoscopic ultrasound had a non-diagnostic rate of about 20%. So one thing that many centers, tertiary centers, did to improve their rates of diagnosis is to adopt rapid on-site evaluation of cytopathology. We didn't quite have this at McGill. They were kind of on call and sometimes could provide the service. But the idea is to have a cytopathologist next to the endoscopist, looking at each slide in real time. As the endoscopist samples the tumor tissue, they can look at the slide right away and determine whether a diagnosis was reached. And if the diagnosis has not been reached, then the endoscopist would go back in and do another pass with the needle, either using a different technique or sampling different parts of the tumor to try to ascertain the diagnosis. As you can imagine, this is quite an endeavor. There's disadvantages to this. You need a expertise that's not always present in an experienced cytopathologist or cytotech. It is expensive, where you need to bring someone else to the room to do the procedure with you. It can be resource intensive and time consuming. In reality, rapid on-site evaluation of cytopathology also was very popular in the United States. Almost every center in the US, tertiary center, had this service, but in Canada, really only 1 or 2 hospitals had the service. In Quebec, only the CHUM had the service on a regular basis. So we had to find another way to improve tissue acquisition that was available for all. Then came the fine needle biopsy. These are core needles that were introduced in 2016. And finally, we were able to acquire a little more tissue, core samples. The needle was the same gauge, 22 gauge, so it's still quite small, but the design of the needle is to get more tissue in a cutting fashion. And we were, for the first time, able to get tissue with preserved histology, with preliminary data showing an accuracy of 90%. Now, the question remained at that time when I first came back to McGill, whether using these core needles alone was as accurate as fine needle aspiration with the presence of rapid on-site cytopathology. So we did do a randomized controlled trial. This was a Canada-wide 7-center randomized controlled trial. It included the Jewish general here. As you will see, you'll recognize many of the names. And obviously, Kevin Washka and José Parent were also part of this randomized trial. And the idea was to compare EUS FMB using these core needles alone versus fine needle aspiration with rapid on-site cytopathology. And you can see that we randomized 236 patients with pancreatic cancer. 115 went to the core needle arm and 120 went to the FNA with rapid on-site cytopathology. Very interesting enough, we showed that the core needle by itself, without the presence of a cytopathology inside the room, performed just as well as EUS FNA with the cytopathologist in terms of accuracy, in terms of sensitivity, and also specificity. And I didn't show the number here. The procedure time was also about 10 minutes shorter without having to wait for a cytopathologist to confirm the diagnosis. And there was also fewer needle passes. There were on average 2 needle passes with a core needle alone versus 4 needle passes when fine needle aspiration was used with rapid on-site cytopathology. The important second question was histology. We looked at how well these needles got histology. And you can see here in blue, these are the core needles. Histology score 3, 4, and 5. 3 being the bare minimum histology, 4 being pretty good histology, and 5 being excellent histology. That was the GI type of explanation to how histology is graded, but it all has to do with the high power fields. And you can see that up to 88% of core needle biopsies were able to attain at least a score of 3 or 4 or 5 in terms of histology scores. And fine needle aspiration had a hard time obtaining any kind of high quality histology for pathological assessment. So in conclusion, in 2022, we've shown that using these core needles is non-inferior to fine needle aspiration with rapid on-site cytopathology. And I have to say, since our study and a few others, the practice of having rapid on-site cytopathology inside the room, even in the US, has dramatically declined with the availability of these needles. We can also obtain better histology. And obviously, these core needles are easy to implement. There's no expertise that you need to have a cytopathologist in the room, and it has comparable costs to the traditional needle. The next question, however, remains whether these core needles would be better for yielding DNA for next generation sequencing. As you know, that's a big field that many of us are embarking on in terms of cancer treatment, of precision medicine. Getting genetic sequencing from pancreatic cancers has been a challenge. We still don't know whether getting core needle biopsies with histology is better than just getting cells. Intuitively, I'm not sure getting histology is much more advantageous over a fine needle aspirate, but that question remains to be answered. Now, tissue sampling in resectable cancer is another question. Most of you know that when we see resectable pancreatic cancer, traditionally, we have offered patients upfront surgery, meaning that we would take this patient directly to the OR without getting tissue diagnosis and doing the surgery right away. As we move to 2022, more and more we're doing preoperative EUS-guided fine needle aspiration, getting the diagnosis prior to the surgical resection. Now, the question really, when you look at these two different strategies, is whether you're willing to risk tumor seeding versus resection of benign disease. We know that the upfront surgery approach, up to 10% of patients will end up having benign disease. So you could put the patient on the table for Whipple surgery, which has its morbidity and mortality, and actually end up with a benign resection, very often from chronic pancreatitis or autoimmune pancreatitis. We looked at this question through a meta-analysis. One of our fellows, Adel, who's now in Saudi Arabia, looked at this question with over 3,000 patients. And we saw that the cancer survival, actually, there were no significantly different between the preoperative FNA strategy versus the upfront surgery for resectable cancer. And more importantly, if you look at peritoneal recurrence, the question of seeding, there was no significant difference in over 3,000 patients between upfront surgery versus preoperative US tissue acquisition. So all in all, it appears to be safe to get tissue acquisition prior to surgery in resectable pancreatic cancer. The seeding risk is very, very small, and you really avoid resection of benign disease. We think that in 2022, pre-op sampling should be preferred over upfront surgery. In many ways, we wouldn't give chemotherapy unless we have tissue diagnosis, and I don't think it's the best practice to go ahead and do very morbid surgery without tissue diagnosis. I'm going to switch gears a little bit and turn to biliary obstruction. Biliary obstruction is when the tumor, and this is obviously the most common presentation of pancreatic cancer due to the location of the cancer, and the tumor really encroaches on the bile duct, leading to obstruction of the bile duct, jaundice, and even cholangitis at times. Biliary decompression is obviously central to the management of patients with pancreatic cancer and evidence of jaundice. It's really necessary for chemotherapy to be given for the simple fact that FOLFIRINOX is very hepatotoxic, and we need to be able to decompress the bile duct before giving such toxic regimens. Biliary decompression also improves the quality of life. We know from actually Dr. Alan Barkin's data showing that when we have biliary decompression, even in the palliative setting, patients do have higher quality of life in terms of digestion, well-being, and overall well-being. ERCP, I'm sure most of you are familiar with this technical approach, is the gold standard for relieving the bile duct from obstruction, especially in pancreatic cancer and malignant distal biliary obstruction. So the idea is to insert a camera. This is a little bit of a different camera than the gastroscope. It is a side viewing scope, meaning that your vision is on the side of the endoscope, and all your working channels is also on the side of the endoscope. You go all the way to the major papilla in the second portion of the duodenum. You use a Seldinger technique to get into the bile duct, make a small incision with a sphinctertome, and then you're able to insert a metal stent as depicted here on the right here, a metal stent going through the major papilla into the bile duct through the tumor. More and more, we're using metal stents. They've been shown to be more robust than plastic stents. But despite the use of metal stents, we know the tumor recurrence, not tumor recurrence, but the stent blockage rate remains very high at 20 to 30%. So what happens here is that the tumor will eventually grow through the stent or over the stent, causing recurrent obstruction. This is obviously very difficult for the patient who have to come back to the hospital for another reintervention. Chemotherapy usually is really stopped during this time, and it's not obviously the best thing for the patients to be stopping chemotherapy when it was going well. So it has major cost effect and also oncological outcome when these stents block. Due to this major, I would say, Achilles heel for ERCP and metal stenting, we've looked at, well, not me personally, but many people have looked at medical treatment to try to optimize stent's function. So in many ways, like in cardiology, where they give aspirin Plavix to improve the function of their stents or to keep their stents patent, we looked at different drugs to try to keep our bile duct stents patent. So ursodeoxycholic acid and antibiotics are the two drugs that have been really looked at and explored in preventing biliary stent obstruction. Unfortunately, this meta-analysis showed no difference and showed no association and no protective effect of using these two drugs to try to improve biliary stent occlusion. There was a very interesting and exciting paper that was published in 2017. This was performed at the Cleveland Clinic, single center, 436 patients. And it showed that chronic aspirin exposure decreases the risk for stent obstruction by 51%. It also showed longer stent patency, overall about 100 days more in terms of length of stent patency in patients with chronic aspirin exposure. Off of this study, there was a lot of excitement in the field thinking maybe aspirin would be a solution to the stent dysfunction problem. Aspirin obviously is very easy to use, very cheap, widely available, and overall very safe. The idea of using aspirin in biliary drainage is it has an effect on the mucin production in the gallbladder, where there's less mucin, making bile more streamlined and less viscous, allowing better flow. There's also an anti-inflammatory effect of aspirin on the bile duct and a potential anti-tumorigenic effect. We aim to confirm these findings. We thought that the findings, although exciting, were prone for type 1 error, given that it was single center and very small. So we did a multi-center study across 10 sites in Canada, also in the United States. We looked at over 1,300 patients and looked at their stent dysfunction and aspirin exposure. Unfortunately, in our study, we showed no association, no protective effect of aspirin on stent function. This was work by Dr. Cristina Candido, as many of you know, who is now a GI fellow, who was previously an internal medicine resident. And you can see here on the Kaplan-Meier curve that there was no advantage of having chronic aspirin exposure. We did identify other predictors of stent dysfunction, such as high tumor stage, smoking, no chemotherapy, and high bilirubin of greater than 120. This was based on a hazard ratio and a multivariate analysis. So overall, there are no proven medical treatment for stent patency in the field of pancreatic biliary endoscopy, which is unfortunate, but I think this is a field that will continue to grow and people will explore other possible medical treatments to improve stent patency. Without a good medication to increase stent patency, we looked at other modalities of biliary drainage. EUS-guided biliary drainage is a new modality where we create a bypass, a new connection between either the duodenum and the common bile duct or the stomach and the left hepatic duct. And over here, we show here a connection, a new connection between the first part of the duodenum to the mid-common bile duct. And you can see here the difference between this and the ERCP is that the stent is above the tumor, away from the tumor, and you're forming a new anastomosis. It's basically a surgical anastomosis performed through the endoscope. The idea is you're away from the tumor, therefore the cancer cannot grow into the stent and cannot grow over the stent, and therefore you will have fewer rates of stent obstruction. The thinking is also that maybe there will be lower risk of post-ERCP pancreatitis as you're very far away from the pancreas. Endoscopic ultrasound guided biliary drainage was very exciting, was first described by Mark Giovannini in 2001. Many thought it was going to change the field of ERCP. And in 2008, it was really identified as a research priority by the American Society of Gastrointestinal Endoscopy. Despite that, however, the volume of US biliary drainage has remained stagnant over the years, with less than 500 cases per year performed in the US. We looked at why, through a survey study, this new technology was limited in terms of implementation, and we identified 4 factors that really limited the adoptability of US biliary drainage. It was felt that there was a lack of expertise in the field. There was also a lack of dedicated device to do the procedure, and a lack of high quality data, and endoscopists overall feared adverse events with this new procedure. Looking at the data, there's actually accumulated evidence of strong data. Dr. Miller, who's at the Jewish General Hospital, a good friend and a fantastic endoscopist, did a meta-analysis regarding this question of 3 randomized controlled trial. Very importantly, these randomized controlled trial used non-dedicated devices for EUS. It used mostly ERCP devices, making the procedure very difficult. So these are randomized trials stemming from real expert centers across the world, in Korea, and also in the United States. You can see here in terms of the primary outcome of stent dysfunction, when compared to ERCP, US biliary drainage had fewer rates of stent dysfunction, as we hypothesized, compared to percutaneous drainage, PTC, and also had fewer reinterventions than PTC. Looking at adverse events, comparing US biliary drainage with ERCP, you can see that the adverse event rate was comparable between the 2 groups, and it was actually safer than percutaneous drainage with fewer complications. Based on this data, the ESGE guidelines, the European guidelines, have advocated for endoscopic ultrasound guided biliary drainage over PTC after failed ERCP. However, ERCP remained the first line. And this was a strong recommendation based on moderate quality of evidence. And one of the limiting steps for US biliary drainage was a lack of a dedicated device. Really, without these devices, the procedure is very difficult and can only really be performed at centers of expertise. Until the advent of these stents, I think some of you have seen these stents before. These are called lumen opposing stents. I'm showing different lumen opposing stents from different companies here. And the idea is it has a cautery tip where you can insert directly to any structure with cautery assistance, and the lumen opposing metal stent can be released. These are very particular in shape. They're very short. They're only 1 centimeter long. It has flare flanges, dumbbell shape, to hold 2 lumens together. The idea is that these stents can create anastomosis by being very short, and also by having these flared ends to hold 2 structures together. So this is the way we do biliary drainage using the stent. Again, we're trying to connect, if you look at the bottom right here, the first part of the duodenum to the common bile duct by creating a new track, and you'll really burn through the duodenum and bile duct with the cautery tip to get in. This is the endoscopic ultrasound view. You can see here the bile duct at 6 o'clock. The endoscope basically sits right here, and you will see a catheter getting advanced very shortly. So this is the stent getting pushed into the bile duct. The catheter is then pushed as far as possible. Bearing in mind that there's a portal vein right there, right under the bile duct. We're careful with not going through the portal vein. And basically the distal flange is then deployed. You can see the dumbbell shape of the stent on ultrasound being deployed. This is an unedited video, so you can see how quickly this procedure can be done. It's a really quick way to get biliary drainage. And you can see here at 7 o'clock, the stent getting pushed out, and you've basically formed a choledochal duodenostomy with excellent drainage of bile. The first reports of this procedure was in surgical endoscopy by Dr. Rasti Kunda. He did 57 patients and showed very high technical success and clinical success. And you can see here that the stent blockage was very low at 7%. After the study, there was a lot of excitement, maybe that this was the new way to do biliary drainage in cancer, given the low rates of stent blockage, and also how fast and easily it can be performed. However, if you look at the technology stages of any new technology, and I invite anyone who's interested in medical device development to look at this paper written by one of our own, Dr. Jeff Barkin. He was the first author on this paper that was published in The Lancet. Basically, this paper goes to how to get different surgical endoscopic modalities from stages of innovation to all the way to long-term adoption. And we can see here that EUS biliary drainage was really in the stage 2A, the development phase of surgical of innovation. And this is where few innovators are performing the procedures and really not adopted by many. To get someone from stage 2A or a new procedure from stage 2A to a stage 3, where many endoscopists are doing this, many surgeons are doing this, we require randomized controlled trials. So the next step for this procedure was randomized controlled trials. We did this, we undertook a randomized controlled trial, which was the first in North America in 2018. We called it the ELEMENT trial, where we compared EUS-guided biliary drainage using this lumen-opposing metal stent to form a choledochal duodenostomy versus ERCP and insertion of a metal stent, which is the current gold standard. Interesting enough, in our study, the median experience of all the endoscopists for this procedure was actually quite low. Only about the median was 2 procedures per endoscopist prior to entering the RCT. The primary outcome of our study was stent dysfunction, either from migration or occlusion. And from February 2019 to March 2022, 144 patients were recruited, 73 were randomized to EUS, 71 to ERCP. I also lost a lot of hair in that time, very stressful situation, but we got this done. The technical success was comparable between the two groups, 90% EUS versus 83% in ERCP. And we can see here that procedure and fluoroscopy time favored EUS. If you look at EUS, the procedure time was 14 minutes. In the ERCP arm, it was 23 minutes. And in terms of fluoroscopy time, very little fluoroscopy was used for EUS at 1.3 minutes and 4.8 minutes in ERCP. Very interestingly, 45% of the EUS biliary drainage was done without fluoroscopy. Clinical success was also comparable between the EUS arm and the ERCP, and so were the 30-day stent dysfunction. So just to note that this is not the complete study. We're not done with the 1-year follow-up, and we decided not to do any interim analysis. We only looked at endpoints that are completed, but we did look at the stent dysfunction rate at 30 days, which was 4% in each arm. Lastly, and very importantly, any new technologies, we want to look at adverse events. The adverse event rate for EUS was 11% versus the exact same numbers of 11% in the ERCP arm. There were no severe or fatal adverse events with EUS. There were, however, 2 severe adverse events with ERCP and 1 fatal adverse event with ERCP with a patient succumbing to cholangitis. This was not significantly different between the 2 groups, however. So from our randomized controlled trial, we can see that the new technique of EUS biliary drainage is comparable to ERCP in terms of short-term outcome. We're awaiting the completion of follow-up data for stent dysfunction, our primary endpoint. But we have already shown that EUS approach is more practical and more efficient than ERCP. That's faster and doesn't require fluoroscopy. We also showed that it's technically easy to adopt. It is comparable to ERCP, even in operators with very low EUS biliary drainage experience. So if we look at the limitations that we discussed regarding EUS biliary drainage, I think we're addressing the limited experts in the field by introducing new dedicated devices that makes the procedure easier. We now have dedicated device to do the procedure, and we're gaining high quality data with emerging randomized controlled trial. Us having done this in North America, a second group in Hong Kong is also doing a very similar randomized controlled trial as ours. And lastly, the fear of adverse events. We now have multiple studies and randomized controlled trials showing no difference in adverse events when using EUS biliary drainage versus ERCP. So summary of biliary drainage in 2022, I think ERCP remains first line. However, we're seeing an increased adoptability of EUS biliary drainage. And this is very important. I think certainly we should go to EUS biliary drainage before going to percutaneous drainage. It's shown to be safer, better, and more effective. I think EUS biliary drainage will be moving forward towards a first-line modality versus ERCP. However, we need more data to support that, and we need long-term data, and we will be performing a meta-analysis once the Hong Kong data is out, and we will also be looking at a cost-effectiveness analysis. Last topic for pancreatic cancer is malignant gastric outlet obstruction. As you know, this is a very common complication of pancreatic cancer. Up to 30% of patients with pancreatic cancer will present with malignant gastric outlet obstruction because the tumor impinges on the duodenum and causes obstruction. Their first-line treatment is similar to ERCP, is where we put a stent through the tumor. This is called enteral stent to establish luminopatency again. But this stent performs even worse than the bile duct stent, where up to 40% of these stents will block, basically. These are uncovered stents, and very often the tumor will quickly grow through the mesh of the stent and cause recurrent obstruction. The new way of addressing this issue is called endoscopic bypass. So this is a technical challenging approach where instead of putting a stent through the tumor and putting it at risk for stent obstruction, we do a bypass where we connect the stomach, the mid-stomach, to the jejunum. This is the ligament of Treitz, and we use again these lumen-opposing stent to make this new connection. And instead of food going down the duodenum, the food goes through this new anastomosis down the jejunum. This is how we do the procedure. We first infuse a lot of fluid in the small intestine to distend the small intestine after the obstruction. Once it's properly distended, we then introduce the echo endoscope to locate this distended intestine, and we use cautery again to get into the small bowel, and you can see here the stent getting released, the distal flange getting released, followed by the proximal flange, and you form a gastroenterostomy connecting the stomach to the jejunum. How about the data comparing EUS gastroenterostomy versus enteral stenting? When I was a fellow, we reported the first comparative study, although this is retrospective, between EUS gastroenterostomy versus enteral stenting. This was out of Johns Hopkins. And we showed that technical and clinical success were comparable in both groups, similar clinical success, but the main advantage is gastric outlet recurrence. So you can see here in the bypass arm, the EUS gastroenterostomy arm, the recurrence rate was very low at 4.3% versus almost a recurrence rate of 30% in the enteral stent arm. There have been many comparative studies since this initial study in 2017, the best one being a propensity study. But before we talk about that, let's look at why these stents block. In our study, we showed that enteral stenting, the duodenal stent blocked because of tumor ingrowth and overgrowth. And in the one case of EUS gastroenterostomy, the endoscopic bypass, where the stent blocked, this was due to food impaction, due to the fact that the patient was not respecting the stent diet. This was the study that I was talking about, an excellent study done in the Netherlands, where they compare EUS gastroenterostomy versus duodenal stenting using a propensity score match comparison in multi-center study. And really what they showed was similar to what we showed, but obviously in bigger numbers. They had 88 patients in EUS gastroenterostomy versus 88 patients in duodenal stent arm. And you can see here that only one patient out of the 88 patients undergoing the endoscopic bypass had gastric outlet recurrence versus 17 patients in the duodenal stent arm. And the time to recurrence was 243 days for US gastroenterostomy and only 57 days and in the enteral stent arm. That has certainly been our experience with duodenal stents at McGill, where most of the stents will block within 1 to 2 months after insertion. They also did a propensity study versus laparoscopic gastrojejunectomy and showed that the endoscopic bypass approach was associated with faster recovery, faster intake of food, and also faster discharge post-procedure. Dr. Miller at the Jewish General again did a systematic review on this. And he looked at US gastroenterostomy versus enteral stenting versus surgery to look at the different outcomes. The primary endpoint being clinical success without reintervention, which is what we want for these patients, is to be able to eat and not have recurrence of blockage. There were 10 studies with over 1,000 patients. And you can see here that clinical success without reintervention strongly favor US gastroenterostomy over enteral stent with an odds ratio of greater than 5. Looking at adverse events of US gastroenterostomy versus enteral stent, they were comparable in both groups. But if you look at US gastroenterostomy versus surgery, you can see that there are fewer adverse events using the endoscopic approach versus the surgical laparoscopic gastrojejunectomy. So in this systematic review, Dr. Miller showed that US gastroenterostomy provides a robust bypass with lower risk of recurrent obstruction compared to enteral stenting and fewer adverse events compared to surgery. Despite this data, US gastroenterostomy has not really taken off outside of expert centers. McGill University Health Center is the only center in Canada performing these procedures as a first line currently. This includes the Jewish. Nowhere else in Canada are they doing this. And certainly in Quebec, the CHUM has not been doing this procedure either. And the main reason is the fear of stent misdeployment. You can imagine you're trying to connect two structures together, the stomach and the jejunum. And if you misdeploy a stent, you have a stent misdeployment and basically a perforation. This is a view of a perforation where you have the small bowel injury here, and the endoscope is actually in the abdominal cavity in the peritoneal space with omentum here at 7 o'clock. So this is obviously a really terrible situation to be in. So stent misdeployment has really held back many early adopters of US gastroenterostomy. The rate of stent misdeployment has been described to be between 7 and 26% in the literature. There are different types of stent misdeployment: type 1, type 2, type 3, type 4. It all involves different injuries. Type 1, having a stent misdeployed with the proximal side attached to the stomach, but the distal end in the peritoneum. And type 2 is where you've injured a small bowel. Type 3 is where you push the stent through the stomach and connected the jejunum to the peritoneal space. And lastly, the type 4 is where you inadvertently connect the stomach to the colon instead of the small bowel. Amanda Marino, who's one of our residents in internal medicine, did a wonderful job looking at this technique that Dr. Bessisol and myself have worked on. In order to circumvent or decrease the rate of stent misdeployment, we've been using these balloons to isolate loops of small bowel to facilitate US gastroenterostomy. These are aortic balloons where we're inserting these at the ligament detritus. And the idea is really to inflate these balloons and occlude the small bowel segment that we want to target between these two balloons. And we can then infuse fluid. You can see on ultrasound here, fluid coming in, distending the small bowel and giving us a big target to form the US gastroenterostomy. You can see the catheter going in now with cautery, and the stent, the dumbbell-shaped stent. This is a much bigger stent. This is a 20-millimeter stent getting deployed, forming the gastroenterostomy. Radiographically, you can see the connection between the stomach and the jejunum. And the idea is using these two balloons, you give yourself more space, and maybe you will lead to less stent misdeployments. Nevertheless, of the technique you want to use, we need to shorten the learning curve of this procedure before it can be adopted worldly. We need to enhance the safety during the learning curve, and we need to The goal would be to get this under conscious sedation. We're still doing these cases under general anesthesia, but we need to make this procedure easier through dedicated devices to really be able to do this under conscious sedation. There are 2 randomized controlled trials ongoing that is looking at this question of EUS gastroenterostomy versus enteral stent. One is arising from Baltimore at Johns Hopkins. We are part of this randomized controlled trial. We are actually the only international site that's part of this RCT moving forward. There is one RCT also coming from Hong Kong, and I believe there's 2 sites in Netherlands who is also trying to start a randomized controlled trial looking at EUS gastroenterostomy versus the standard of care. The MUHC experience, just to let you know, this is unpublished data. Abdurrahman is actually working on a paper using this data. If you look at what we've done so far at the MUHC, we've done 36 EUS gastroenterostomy. Our technical success is very high at 97%, very high clinical success. And stent dysfunction or reobstruction only occurred in 2 patients, 6%. And we only had 1 adverse event in 1 patient. And in terms of stent misdeployment, we had none so far, knock on wood. So this is the experience at the MUHC so far. It's very exciting what we're doing now. We can also do double endoscopic bypass. Abdurrahman described this procedure very nicely where, we can do a gastrojejunostomy and also a choledochoduodenostomy, draining the bile duct in the same session. This procedure, for example, took 30 minutes to really get a gastrojejunostomy bypass and also a biliary bypass done. So in conclusion, for tissue acquisition, EUS tissue acquisition is the gold standard for pancreatic cancer. The core needles are the needle of choice currently. It remains to be seen whether it is better for genetic sequencing, and preoperative tissue sampling should really be considered over upfront surgery. In terms of biliary obstruction, ERCP remains to be the first line. However, EUS biliary drainage is catching up fast. It is definitely the modality to be chosen over percutaneous drainage, and it soon will be an alternative to ERCP as a first line. We're awaiting long-term data to further characterize the use of EUS biliary drainage, and we know that there are no proven medical therapy for stent patency thus far. Lastly, for gastric outlet obstruction, those of us who do this, we know that EUS gastroenterostomy is likely better than enteral stenting and safer than surgery. RCT data are pending or are coming, and we also need to develop a standardized technical approach to enhance the adoption of this new technique. This is very interesting and exciting times for endoscopy. I think what's happening in endoscopy is really what happened in cardiology many years ago when a lot of the surgical treatment became an interventional modality, and we're seeing a similar shift where more and more endoscopic treatments are offering more than just diagnostic capabilities. For example, we have these RFA tools that are coming out that can do local ablation of cholangiocarcinoma, pancreatic cancer. We can do EUS-guided chemoablation. On the diagnostic front, we can now do EUS-guided liquid biopsy of the portal vein for better staging. And we can now do anastomosis, and hopefully it will move beyond the world of cancer where we can do anastomosis for bariatric surgery, for example. And that's it. Thank you very much.
Thank you very much, Emmy, for this wonderful, comprehensive lecture, and really congratulations on all the advancements that you've done in this field at the MUHC. I invite people to enter their questions in the chat, and as people are doing this, I have a question for you, big picture question. So a lot of what you're describing in these kind of procedures, I assume they're more supportive palliative type care, right? So what kind of change in life expectancy are you giving patients that have pancreatic cancer once they start having these obstructions? Are we talking about months? Are we talking about, can you add years to someone's life?
So for biliary drainage, for example, if EUS biliary drainage could be proven to have less dysfunction, that equates to patients not having any kind of chemotherapy interruptions. So it remains to be seen whether that would lead to a longer life expectancy. I think especially in the neoadjuvant setting where we're giving a lot of neoadjuvant chemo to pancreatic cancer patients, it definitely could potentially have a survival benefit. For gastric outlet obstruction, unfortunately, that is mostly in the palliative care setting. These patients who have gastric outlet obstruction do not usually have a tumor stage that allows for surgical resection. So what we're trying to do there is to optimize the palliation of these patients and not have them come back to the emergency room with recurrent obstructions.
Fair enough, fair enough. In your first topic, you discussed that rather than doing a Whipple's, you would do an endoscopic approach to make the diagnosis of pancreatic cancer. So somebody has a mass on their pancreas, all the other tests, MRI, CT, ultrasound, you're saying that you can overestimate the diagnosis of pancreatic cancer and do Whipple's and this be sort of a benign lesions, and you've done a major operation which was not necessary, and you could approach this endoscopically if I understood correctly, right? Is this something that happens frequently, that the diagnosis, can't the testing that we have, the imaging test can't differentiate between a malignant mass and a benign sort of tumor on the pancreas?
Yeah, so Nadia, so they've done large population studies of American kind of census and large population-based studies showing that up to 10% of Whipple surgery, you end up with benign tissue on your specimen. One of the pathologies, which is autoimmune pancreatitis, and also chronic pancreatitis, are very often associated with a mass that looks exactly like cancer. So these are the cases where you want to try to avoid resection. And I think our surgeons have done a wonderful job here. We see most of these cases where we do the biopsies pre-op. I don't think many of us are doing many upfront surgeries anymore. But I think some centers still do, but we're moving away from that.
Okay, thank you very much. So a question here about when or should we even do screening CA19 in certain patients?
So CA19-9 is a controversial topic. You're supposed to use it as a way to follow tumor recurrence if they had a high tumor marker to begin with. As a shotgun approach to try to use it as a screening tool, I believe is the wrong way to go about it, because other things can cause elevation of CA19-9, and you're stuck with a non-specific test. I think when you have a suspicion of pancreatic cancer, whether that be on imaging or you have a double duct sign or a question stricture in the bile duct, that's when CA19-9 comes into handy. I wouldn't do that as a shotgun approach in a perfectly healthy patient.
So no screening for CA19 in the routine population. Corey Miller says, amazing talk, incredible work, Dr. Chen. Are the new stents used for, that's great. Are the new stents used for endoscopic bypass expensive? And does this impact your decision for which treatment to offer?
So they are very expensive. I have to buy Dr. Bitton a bottle of champagne every time we take a stent. We have two cost-effectiveness studies now. One of it is underway. If you factor in the readmission from stent obstruction, the patient coming through the emergency room, getting admitted for 1 week on the hospital floor, then there's no question that these stents actually become very, very cheap if you factor those things in.
Do you have any issues within the MUHC of having access to the tools and stents that you need, generally speaking, or is it?
Dr. Bitton has been extremely supportive in helping me acquire them in any way necessary. But no, all kidding aside, we receive great support from the MUHC. When Eva was DPS, we actually had met about this and was supportive regarding this. So we've had good support to get these stents.
Fantastic, fantastic. So if there's no further questions, we'll stop there. I really thank you and congratulations on all your terrific work, your FRSQ, and everything you're bringing to our patients and our residents and our trainees at the MUHC with all these advances. And Eva's just responded, this is important work. Congratulations. So thank you very much, Jenny, for joining us today. Thanks everyone for joining us and have a great day.
Thank
Bye-bye.
you.
Thanks. Bye-bye.